The path to parenthood isn't always a straight one. For LGBTQ+ parents, it can be especially complex, and too often, our stories go untold. This is Proud Conception. I'm your host, Rachel Gresson, and together we're giving voice to the many ways our families come to be. We're diving into how we build our whānau, raise our little ones, and shape a world where they feel seen, safe, and proud. Kia ora e te whānau, and welcome back to Proud Conception. When this episode airs, I will have just finished my first day back at work following 12 months on parental leave. Please send me all your good luck vibes. I'm very nervous to be back in a corporate setting after so long away, and quite frankly worried that my brain just does not know how to do the things it's paid to do anymore. But alas, I know this is a struggle that many a person before me has overcome, and so I will too. But still, I won't turn down any good vibes if you're sending them my way. Thanks. This week's episode is our second expert episode of season 1. Yay! I was absolutely thrilled to connect with Dr. Olivia Stuart, a doctor from Fertility Associates. She came so highly recommended from many of you. As we all do, we discuss our healthcare providers and get recommendations where we can, and many LGBTQ+ folks who have used Fertility Associates to grow their family could not speak highly enough of Dr. Stuart, or Olivia, as she kindly agreed to let me call her. She is a compassionate, highly skilled, thoughtful healthcare provider, and I was genuinely so chuffed that she agreed to come on the podcast. But, and this is a big but, there is no production team or broadcast platform or whatnot behind this podcast. It's just me, Rachel, with a secondhand mic from Marketplace and the love of a good yarn on a topic that I feel very passionately about. Which means, unfortunately, in the case of this very, very special episode, my tech let me down and I just couldn't rectify it. Olivia and I chatted for about an hour, but I only have 43 minutes of our delightful conversation because the remaining minutes just didn't upload to my editing platform. I am so unbelievably gutted, and I'm really sorry to you all for losing those precious minutes. But the conversation that I did capture is really fantastic, and I don't believe in gatekeeping information, so I'm releasing it anyways. The perfectionist in me is absolutely mortified, but we're not letting the perfect get in the way of the good, and we are giving people the information they want. There was really just one final question that, slightly ironically, got missed from the recording. My last question to Olivia was around how places like Fertility Associates think about the LGBTQ population and how they can make sure their services and care are really inclusive for our communities. It won't be a surprise to anyone listening that the LGBTQ+ communities have varied experiences in places like fertility clinics, some and many positives, but also others where we've just felt not seen or excluded, misgendered, or worse, discriminated against. I will lightly summarize Olivia's response at the end of our recorded conversation because she did raise some really great points. But of course, I don't want to speak for her. And I will say that if you love this conversation and you get something out of it and want to see more of it, perhaps another episode with Olivia or one of her colleagues, please reach out to me. If I can show evidence of audience members really enjoying and being informed through these conversations, then I'm showing guests, particularly expert guests, why this is a worthy endeavour and one they should spend some of their limited time on. So please get in touch via Instagram. We're at Proud Conception Pod, or email proudconception@gmail.com, and please let me know what you think. We also couldn't cover everything in my conversation with Olivia. In fact, we barely scratched the surface in this conversation. So I'd love your thoughts on particular topics you'd like to see from a fertility clinic perspective as well. Okay, so today on the pod, we're talking to Olivia. Olivia is a gynaecologist and an obstetrician and a fertility subspecialist, which means she can see women and people assigned female at birth the whole way through their reproductive, fertility and birthing experiences. This conversation is a bit of a primer, a fertility clinic conception journey 101. Olivia explains procedures like IUI, IVF and ICSI, what sort of factors are at play when she recommends any particular procedure to an individual, and how for those last two, it's a bit of a numbers game. and that attrition is part of the process and something to really mentally prepare for in advance. Our conversation then traverses into more specific information around gamete donation, so sperm donation and then egg donation. And then you will hear me, unfortunately, pop back into your ears to round out the conversation, capture those minutes that were not recorded. Okay, I've gone on long enough. Here's Olivia. Enjoy. Kia ora, Dr. Olivia Stuart. Welcome to Proud Conception. Thank you so much for joining me today.
Kia ora, Rachel. Thank you so much for your invite.
I am really excited to talk to you because, of course, LGBTQ people don't have to go through fertility clinics to grow their families, but many people do. And having done the process myself, I think it's one of those processes and industries where you don't know what you don't know. And until you've done it, it all feels a little bit sort of abstract and artificial to a layperson. So yeah, I'm really pleased to talk to you today and just sort of unpack the process and clinics a bit generally. But I will say on that note about generally, we are not going to cover everything today. There are lots of nuances about, the couple that turn up to your door or the individual that turns up to your door. I appreciate that the procedures and processes that you might, advise them would be different for everybody. And a lot of it sort of, in air quotes, depends on the situation in front of you. But it would be great to sort of talk through some general things and give the listeners a bit of guidance as they maybe start their journey looking at how to build their whānau. So yeah, kia ora, and thank you for being here.
Kia ora, Rachel. Thank you so much for having me.
Why don't we start with your rainbow roll call? So I know you're not in a queer family, but I ask all my guests as a way to get to know them, sort of who's in their whānau and tell us a little bit about them. So let's get to know you.
So I'm a mama of two little boys, 10 and 11, 12 tomorrow, of Tangaroa and Mikaere. And so my babies are half Ethiopian, quarter Māori, quarter New Zealand Pākehā.
Oh, gorgeous.
We have two girl doggies who you might potentially hear during the podcast scratching on the door behind me, trying to get in. They've already done that twice already. Marley and Willow. My boys wanted baby sisters, so we compromised and we got two girl Siberian Huskies. I te taha o tōku kuia on the side of my nana. O Māpere te moana. Lake o Māpere is our lake. Te ahu is our maunga. Yeah, our marae is Parawhenua marae. He iwi, Ngāpuhi is our iwi. Ko Ngāti Hineira te hapu. Ngāti Hineira is our hapu. On the side of my granddad. Ko Ruamahanga te awa, so Ruamahanga is our river. Ko Rangitumau te maunga. Tumau is our maunga, our mountain. Ko Papawai te marae. Papawai is our marae. Ko Ngāti Kahungunu ki Wairarapa is our iwi, or te iwi. Ngāti Kahungunu ki Wairarapa is our iwi. Ko Tāneroa te hapu. Tāneroa is our hapu. Ko Tāwhao Tāwhirimatia Ngātuere te rangatira. Tāwhao Tāwhirimatia is our chief.
Kia ora.
Yeah, kia ora.
And of course, we're getting you on today as an expert episode. You're my second expert episode, so thank you for being my second guinea pig. Could you briefly describe some of your background, professional background and credentials?
So firstly, I'm an obstetrician gynaecologist. So that's how most steer their pathway through into the fertility, because it's a subspecialty of obstetrics and gynecology. I have worked a lot overseas. I actually qualified from Otago, but went straight to Australia for my trainee internship. Did 4 years there, went to, did the OE and went to the UK for a couple of years, ended up pushing that out to 4 years, but still working in O&G, and then came back. I worked in Australia, Hong Kong, and back in Australia in O&G, and then did my subspecialty training in fertility in Sydney and back here in Aotearoa. So yeah, I'm a subspecialist in reproductive endocrinology and infertility, which is essentially like a subspecialty pathway from obstetrics and gynecology. I loved learning, and so I wanted to know as much as I possibly could about this part of our specialty, and just be able to give my patients the best information, the most up-to-date information that I can. Yeah, we also do some part of obstetrics and gynecology as well. We all have different sort of timetables for our week, and so how I structure mine, because I love still doing obstetrics, is that I'm also an obstetrician, and it's really nice to be able to follow the fertility patients through from
Yeah.
my fertility practice and then deliver their little miracle babies at the end. So that's what I really love doing.
Yeah, that's particularly beautiful, isn't it? You know, a couple or an individual could come to your doors at Fertility Associates and, you know, be wanting a baby and needing some help to do so. And then you can come all the way through the other end of the journey and help bring that little one into the world with them, which is, yeah, very cool.
Such a privilege.
And how long have you been at Fertility Associates?
So I came home 12 years ago. So I've been there for 12 years now.
Oh, right. Okay, cool. Got the run of the place.
Yeah, so I practice in Auckland, but also do clinics up in Te Taitokero and Whangarei through Ngāti Hine there.
Oh, gorgeous. Cool. So I know there are many ways that members of the LGBTQ plus community might come to you needing help to grow their whānau. Sort of depends who's in front of you when they sit down in the consultation chairs, I suppose. But that notwithstanding, could we start with sort of a bit of a 101, a bit of a primer? If someone comes to you at Fertility Associates in the clinic and they're queer and they need help starting their whānau, what are sort of the ways that are on offer for them to start?
So yeah, that's part of our first chat when we're first meeting couples from the LGBTQ community. We're sussing out whose eggs they potentially want to use, whose sperm, and then who to carry. So it'll really depend on what they have between them, and then what else they need outside of their relationship that we can help provide. They might have like a personal egg or a personal sperm donor. They might have a surrogate, or they might need to use one of our sperm donors, our clinic donors, or our clinic egg donors as well. So yeah, we're really just trying to suss out what ingredients they have between them, and then how we can help to, complete the full picture of ingredients that they require to have their pēpi.
Yeah, you're 100% right. We are usually missing one, if not two, of those special ingredients, aren't we, when queer folks turn up to your doors? So we're definitely going to talk about gamete donation. But before we get there, I think a number of people listening to this podcast, and certainly people who have been on the podcast sharing their own journeys, have thrown around some of the terms of the processes they've been through with a fertility clinic. And I'd love your help to sort of break those down and maybe compare sort of the different processes. So I think the ones people usually hear about are IUI, IVF, and then ICSI. Could you give us a bit of a entry-level knowledge base into those ones?
The main differences between IUI and IVF is really the sperm quality, but also chances of a baby. So you have to have like completely normal number and moving sperm to be able to do an IUI cycle. Which is essentially taking the sperm, washing it, prepping, and then putting the best sperm into the recipient's uterus at the time of ovulation. So we have to have at least 10 million normal moving sperm to be able to guarantee the best pregnancy rates with that. Also, the wahines, or the person receiving the sperm, also has to have patent tubes. So if the sperm is lower quality, if we're not getting that 10 million moving sperm, or the recipient has blocked fallopian tubes, then we're doing IVF. And again, if the sperm is all normal, then we are just doing IVF, taking the recipient's eggs, or the egg donor's eggs, putting them together in a dish with the sperm, letting the best sperm fertilize the eggs, survival of the fittest.
Yeah, who can get there first, sort of thing. Yeah,
that's right, exactly. And letting nature choose best, because nature is better at choosing than we are. If something's low on the sperm, like we'd be worried that the sperm's not going to fertilize the eggs, that's when we would do ICSI. So that's for like low sperm counts, reduced sperm motility, where the sperm's not moving as well. That's a scenario where we'd be worried if we tried to just put them together in a dish in the lab, we'd be worried that the sperm's not going to fertilize the eggs. That's when we do ICSI, and so that's intracytoplasmic sperm injection. Our embryologists basically look under a high magnification microscope. they select the most normal looking, most motile moving sperm, and then they inject one into each of the eggs to make fertilization occur. So certainly it depends on the sperm, it depends on the fallopian tubes, but also pregnancy rates. The differences between IVF and IUI are about 2 to 3-fold higher chances of a baby with IVF compared to IUI. So,
Right.
yeah, those are the main things that we talk about. It will come down to basically the age of the person assigned female at birth, that's whose uterus is being used to carry, and also if they're using their eggs, because if they are younger, then their eggs are younger, then they've got like good quality eggs, and that will give them the highest chances of a baby. If the sperm is normal, then IUI is a reasonable thing to do. But as we are born with our eggs, as we get older, our eggs get older too. So for the person assigned female at birth who is using their eggs, basically as we get older, our eggs are more likely to make genetically abnormal embryos. So it's about 50% at the age of 38, where half the embryos that we make will be genetically normal, the other half will be genetically abnormal. So it's around about that age that, we are potentially talking about IVF. The other thing to also mention is that most individuals are trying to have usually 2 babies as opposed to just the one. And so with IVF, we're trying to make as many embryos, and we freeze those embryos. So they don't age when they're frozen. So if we put the first embryo back, they have a pēpi, they're pregnant for 9 months, breastfeeding for another year, they come back in 2 years' time where their egg numbers are going down, but also, their chances of a pēpi are going down, risk of miscarriage is going up. If they freeze embryos with IVF, those are frozen in time, they're always going to have the best chance of a baby, lowest risk of miscarriage or a chromosomal abnormality at the nice young age they are when we take the eggs from their body.
So it's not just a case of everyone enters at IUI and you sort of work your way up the ladder of intervention, I suppose, based on lack of success. There are other elements that go into it that might prompt you to recommend one procedure over the other.
Absolutely. Yeah, absolutely. So it comes into, the age of the person whose eggs we're using, and certainly tubal patency, the count and quality of the sperm, how many pēpi they want to create for their whānau. So there's lots of factors, and we really we get all that information at the first consultation, so then we can steer them along the right pathway.
I had a woman on, I think it was my first episode actually, who also threw in another term that I hadn't heard of. I did IUI for my first and ICSI for, I was going to say IVF, but ICSI, the ICSI version of IVF for my second. And she, the guest that I'm talking about, she also did a rescue ICSI, which I hadn't heard of. So perhaps you could explain rescue ICSI if that's something that you do at FA as well.
So what we understand as rescue ICSI isn't like a recognised fertility procedure. So it's where we put eggs and sperm together in a dish with IVF, and then if fertilisation doesn't occur when we do the fertilisation check the next day, then the embryologist can try and fertilise those eggs again with sperm. It's not a common practice, I would say, in the fertility world. I would think it would be in the sort of experimental phase, but certainly from what has been presented before in previous fertility conferences, the success rates for it are not high. So that's why it's not routinely offered. It's very much a attempt to try and achieve fertility. I mean, certainly if there was failed fertilization with IVF, what most units would do is do the cycle again and then do ICSI the next time.
And so with ICSI and IVF, well, I should say, with IUI, you have the procedure in the clinic and then you're sort of sent on your way and you've given, 10 days to 2 weeks and said, come back for a blood test and we'll see how we got on. With IVF and ICSI, if you're a intended parent or a hopeful parent, your experience is a little bit different because the ICSI or the IVF procedure happens in the lab, and then you get updates from the clinic about sort of how those, I guess they start off as blastocysts and end up as embryos if everything goes right. So could you talk us through sort of what that looks like from the first day that we hopefully have fertilization?
Yes, so Rachel, you're exactly right. There is unfortunately an attrition as we go along. So on the day of the egg collection, we can say the number of eggs that are collected, and then depending on the fertilization method. So if it was ICSI, the embryologists actually have to strip the outside layer of cumulus cells away from each egg to do the fertilization, so they can already tell which eggs are mature, and then only inject sperm with ICSI into the mature eggs. So we can know the number of because not every egg, but most eggs are mature. If you're doing IVF, we don't have to strip that cumulus cells off. So the eggs and sperm get put together in a dish in the lab, and then the next day fertilization check occurs. The same time as ICSI, but without knowing what the maturity are of the eggs at that time, they just all put together. So yeah, certainly most mature eggs will fertilize. So about 75% to 80% fertilization is a normal fertilization rate. But it's unusual to get 100%. Because often you're going to get some immature eggs, which you'll either not inject on the day of your egg collection because you know that they can't be fertilized. The eggs have to be mature to be fertilizable. Or you'll find that out the next day with IVF when you see the fertilization rates, and then the scientist can say, oh, this one didn't fertilize because actually it's an immature egg. It was never going to fertilize in the first place. Then so about 75 to 80% of eggs will fertilize, and we find that out on the next day. And yes, that's the first phone call after the egg collection the next day from our embryologist to tell couples how many fertilized eggs they have. And then usually we would reserve the next call until day 5. So yeah, over that time, the embryos are maturing away inside the lab, hopefully growing sort of exponentially, going through their normal cell divisions. So on day 5, we would expect to see a blastocyst, which is 100 to 150 cells. And so on that day, again, that's when the next phone call comes from our embryologist on day 5. If we are doing a fresh embryo transfer, then we would be calling our recipient in to do their embryo transfer on day 5, and then also telling them about what all the other embryos are doing. So selecting the best one that looks the most perfect, either hatching or expanding blastocyst on day 5, and then also just letting them know how all the other embryos are going in that cohort. So having an embryo transfer on day 5, and then day 6, and even day 7, we keep an eye on those embryos and are giving updates. So then the extra embryos that make it and are good quality, those ones are being frozen, and we're informing couples or recipients at that time how many embryos they have that have been frozen.
Interesting. What would prompt you to recommend a fresh embryo transfer versus freezing them all and doing a transfer at a later date?
There's lots of things that would make us advise against a fresh transfer. So the big one is something called ovarian hyperstimulation. So if we've got lots of eggs, if we've got a high estrogen, so usually 15 or more eggs on the day of egg collection, estrogen levels 10,000 or more, we would be increasing the risk of that recipient having OHSS if we use the conventional trigger overdrill, and if we did an embryo transfer, we're almost guaranteed to give them ovarian hyperstimulation. So that's the one thing that we don't want to do. We want our healthy recipients to stay well and healthy, and us not to hospitalize them with OHSS, which is, particularly life-threatening conditions. The way that we get out of that is that we give a special type of trigger, an agonist trigger, and we make their embryos, freeze them, and don't put an embryo back. And those are the ways that we avoid giving OHSS. So that's the big main factor. There are other reasons why we would do freezels. There might be things that we've found along the way, like polyps or swollen tubes or scenario and high progesterone levels. Those things can reduce the chances of implantation. So that's why we would do a freeze-all as well, another scenario. Address those issues, have the polyp removed, have the tube removed or clipped, and then wait until that's been resolved before we put the embryos back into the best place that is most hospitable and going to give them the best chances of a baby.
I really appreciate you talking through all of that, particularly talking through, that attrition rate, because I know that was, hard to get your mind around, like hard for me to get my mind around when we were going through the process, and certainly for, friends and whānau who have done it as well, because you get all these eggs retrieved and you're super happy about that, and then you just watch the numbers sort of go lower and lower as the days of, development go on. So, it is a good thing to know that information before you walk into the IVF process, so you're ready for that and you're not disappointed when they start to go down, because they will go down. That is just the nature of the game, isn't it?
Absolutely right. That's what we try and prepare people for in our consultations about that attrition rate. We sort of give them an estimated number of eggs, and we can estimate that based on their AMH. And then we talk about that attrition, so we can talk about how many embryos they potentially could have. But also our consenting process is basically videos of each of the different steps. So it really reiterates that attrition as well in those videos. Yeah, so absolutely. It's important information to be prepared for, because otherwise it can be absolutely quite a shock when the numbers just keep going down and down and down.
So parents to be who are listening, don't just click through those videos, watch them and take notes. They're there for a reason. But also with IUI, it was good to hear you talk about those success rates in realistic terms, because, we all have those friends who got pregnant on the first IUI and isn't that amazing? And we've all got our fingers crossed that that's going to be us, but it's more likely than not going to be us. And so it's also the guest I had on most recently, who I have not yet aired her episode, but it's coming soon, talked about how her and her partner had sort of a limit in their mind when they walked into the clinic. So we're going to try IUI 3 times, and then we're going to have a pause, and we're going to reassess as a couple, and, what do we want to do next? And then, if we do IVF, then we might do 1 embryo transfer, and then we're going to pause. And so she had these gates at where they wanted to check in as a couple and see, are we still emotionally prepared to keep going? Are we still financially prepared to keep going? And all of those different considerations. So it is important to think through. We want it to all be happy and, all positive, but you also do have to look at the numbers and the stats around what success rates look like, don't you?
Absolutely. Yeah. And it's a very sensible thing to do.
So I'm keen to talk about gamete donation. It is often a big hurdle for couples in the queer community. Like you said, we are missing at least 1, if not 2 ingredients. Let's talk about sperm donation first. So how does sperm donation at Fertility Associates generally work? Where do these sperm donors sort of come from? How many are there waiting in the wings? And I guess the other main thing that we hear about is these very long wait lists. So how does that all work from the clinic's perspective?
So we have a TPR team, or third party reproductive team. And so they're constantly doing recruitment drives. And so we're getting over 100 donors, sperm donors per year now, which is great. I mean, we get many more than that, but once we've done the screening and taken a medical history and family history and all of those things, we are getting over about 100 usable sperm donors every year, which is great. So they have been able to get it to the point where actually IVF donor sperm waitlist is pretty short. You can sign up straight away, and in the time it takes you to do the necessary workup, so your counselling, your testing, then essentially by the time you've done that component, you're ready to start using your donor with IVF.
With IVF, though, that's the key difference, isn't it? Yeah,
right.
Right.
That's the key difference, sorry. So with IUI sperm, so that we talked about that earlier, having to be completely normal, we don't have as many on our books for IUI quality sperm. So the current wait time is about 2 to 3 years at the moment. So yeah, that's our clinic donors. We have immediate availability for sperm donors that are IVF quality, few, and a 3-year wait time to use our one of our clinic donors for IUI. If you are wanting to go down that IUI route, potentially finding your own personal donor would be a quicker process. So basically, they need to come in, meet one of the fertility doctors, have their counselling. They have their genetic testing, and then their sperm is quarantined for 3 months, and then they would be suitable to start using. And so part of our counsellor's appointment is not only telling people where donors advertise, but also giving language to our recipients to potentially broach it with somebody that they might have an inkling about, but they're just not sure how to ask. So yeah, our counsellors or clinical psychologists can help to find your own personal donor as well.
Yeah, it's not exactly, Friday night drinks conversation, is it? Just, oh, by the way, also, we've been wondering if you wouldn't mind. So that's really useful that, that's part of the support that you can get from your counselling appointment is, thinking about how you'd grow your own family and what gamete donation means for growing your own family, but also some of that language to support personal donation if you need to. It's interesting what you say about, the wait time is longer for IUI because that sperm mobility and sort of quality is just not there from the donors that are coming in and recruited. Does that match sort of all of New Zealand men? Like, are we just seeing this, I don't want to say lack of quality. What's the word I'm looking for? Are we just sort of seeing a degrading perhaps of sperm quality generally across the population?
It's a worldwide phenomenon. Yeah, it's a worldwide phenomenon. So guys now are less fertile than their fathers and less fertile than their grandfathers. There is a steady decline in sperm counts. And the proposed mechanism is maybe all the environmental toxins and exposures that we're exposed to now in our environment, the plastics, phthalates, all those sorts of things do have an impact on lots of bodily functions, but potentially also sperm counts. Yeah. So certainly it is a worldwide phenomenon.
Yeah, it's really interesting, isn't it? I can't, despite having gone through this process with, my wife and now have 2 boys of our own, I can't say aside from that I've spent much time thinking about sperm quality, in a lesbian relationship. So maybe I'll put that on the reading list at some point. But in all seriousness, so once you sort of get to the top of the wait list, whether that's IVF or IUI, how does sort of donor matching work, like the sperm donor matching with the recipients? Because you do hear some stories of people being presented with 7 possible options and other stories with people presented with 2 options. So how does the matching sort of occur?
Good question. Usually it comes down to ethnicity because often recipients are of a certain ethnicity and they want their donors to be the same ethnicity. So that's a major factor. And also donors. Not only as recipients can specify who receives their gametes. So there is, the matching process is not only taking into consideration ethnicity, what the donors and the recipients' preferences are, but also the other main one is genetic testing. So we're all generally carriers of certain genetic conditions. We might not have any family history in our whānau of genetic conditions, but it just takes one carrier having a baby with another carrier to have a baby with that condition. Commonest one's cystic fibrosis, and so 1 in 25 of the population have one of the cystic fibrosis genes. And so that has happened several times before, where babies are being born with cystic fibrosis to parents that are well, but they didn't know that they carried cystic fibrosis gene, and it's been upsetting for them. So that spurred fertility clinics around the world to start doing testing of not only whose eggs are being used, but also whoever's sperm's being used to create the pēpi, and just making sure that they don't carry the same genetic conditions. So we're not putting together, matching whoever's contributing the eggs, whoever's contributing the sperm to the pēpi. So then that pēpi could have that genetic condition. It's another big thing when it comes to matching. The donors and the recipients have this genetic test. We use Invitae in the States. So it's looking at 555 genetic conditions.
It's a lot, isn't it?
And then,
Yeah.
so we just make sure, we don't match two together that are carriers of the same condition. So then they could have a baby, a pēpi with that condition. So that's another one of the main things. That usually it's ethnicity and that reproductive genetic carrier screening test are the main things.
Okay. So it's not often the donor preferences. It's not, that's not usually the main factor. But do a lot of donors have preferences, and specifically, I guess, for my community, do a lot of donors say, we don't want to donate to a queer couple?
I haven't heard that,
Cool.
but sometimes they might not want to donate to a single person. Yeah, and they would prefer to donate it to a couple as opposed to a solo parent. So yeah, it's that would be the less likely sort of, I suppose, even rare event that donors would specify that. I think by far the commonest one would be, ethnicity would be the prime sort of reason to direct their gametes to. Yeah, and obviously because of the ethnic minorities in Aotearoa, so particularly Māori, Pacifica, we have a lot fewer Māori and Pacifica donors on our in our books. Then they really are reserved for Māori and Pacifica recipients. But by far and away, the majority of our donors would be Caucasian and then Asian ethnicities.
It's a tricky process to line it all up, isn't it? It's not just a case of take a ticket and join the queue. There are multiple, as you've talked through, there's multiple other factors that go into what is ultimately presented to a person or a couple at the end of their time. And you mentioned at the top that many couples will be looking to have more than one pēpi, and they, might want 2 or 3 kids to make up their family. So how do you allocate enough sperm so that families can grow? Because I know that, for example, one sperm donor can contribute to, is it 10 children across, 10 families? So how do you make sure that there's enough, sperm allocated to support each of those families having more than one child?
Yeah, good question. So it is either allocated to one of the partners or both, like if it was in a same-sex female couples and both wanted to use their eggs, then it would be allocating that couple enough sperm. And so if it's IUI, certain number of IUI quality sperm straws, or with IVF or ICSI, you don't need to have as much. You don't need to have as many straws of sperm. So, it would be a lot fewer straws of sperm for a couple or an individual that's using the sperm through IVF and ICSI. Essentially, it could be like 5 straws for an IVF ICSI recipient, because they're usually going to be able to create their pēpi and whānau within 5 IVF ICSI cycles. Whereas IUI, you obviously have to have so many more straws, and you could have like 10 or more IUI quality straws for the recipients to be able to create their whānau from that. And, usually there will be surplus from that donor as well. So in case they've used up all of that with IUI, then they've got straws left there that could be used through IVF, or they might have further IUI straws there. But usually if you're using multiple straws of IUI and not having a pēpi, often people will move to IVF fairly quickly.
For lots of different reasons, right? There could be other things going on, or it is personally, as I know, it is heartbreaking to go in month after month and not have success. So there's also, when you increase your chance of success going for IVF, and you weigh up the cost of that. There's so many factors that go into it, isn't it? It's certainly not. That part's the science, but the decision making is the art, isn't it? Because it's not necessarily, one size fits all for everybody, is it?
So true.
I don't want to give the sperm donors all of the attention. So can we turn to egg donation? I know very little about this process. I was very lucky to use my own eggs. So how does the egg bank at FA work? And how does that sort of matching process and recruitment and all of that work?
So yeah, we're constantly, our TPR team, third party reproductive team, are constantly recruiting egg donors as well. And so we have developed over the years a bank, but it's obviously in demand. So it very quickly gets used up. So at the current time, it's about a 3-year wait to be able to use an egg donor, because that's how much the demand is for what supply we have. Yeah, so it is quicker if you are able to find your own egg donor, either asking through, whānau or social networks, or looking through, social media platforms where people can offer, where you can, ask if anybody is prepared. It's certainly a quicker process than using one of our egg bank donors. Occasionally we get a clinic egg donor who doesn't want to go on the bank, but they do want to do a one-to-one donation. But again, that's often very few and far between, and they often get allocated very quickly based on, because it's in such demand, those donors. So yeah.
A one-to-one allocation, does that mean, like, I don't want to go on the bank, I don't want my eggs to be used for multiple different couples, but I'm keen to donate to one particular couple? And is there a process where the couple and the recipients actually meet and do counselling together, or is it still sort of like not anonymous, because I know there's the Heart Act and all of those sort of legal compliance things, but sort of that arm's distance away?
That's right. So the egg bank donors, they have multiple cycles and bank a high number of eggs, so they can donate to multiple recipients, whereas a one-to-one donor, they just donate to that. They haven't banked their eggs. They start that process once they have been matched up with a recipient, and then all of their eggs will go to that one individual. They won't be allocated to anybody else.
Okay. In the egg bank group, I think you mentioned that you sort of end up with about 100 sperm donors a year that have usable, viable sperm that can go to people waiting. I imagine the list is much, much, much shorter for the egg donors. Are we talking single digits, or are there a few more kind souls out there who are, helping people grow their whānaus?
At the current time, we're talking single digits, because as you can appreciate, they come through, they freeze their eggs, and very quickly, because we've got, such a high demand, a long queue, they quickly utilised. So it's very low at the current time, but we're constantly trying to recruit new donors. But it's inevitable that, the supply is so few, they readily get taken up very quickly by the huge demand.
You can see, there's probably many reasons for why there's so many differences between sperm donation and egg donation. But probably the most obvious one is the time and effort required to donate. I have done an egg retrieval, which is the process that an egg donor would go through, right, to donate their eggs. And it's not a quick process. In my case, it was reasonably painful, to be honest. It's quite different than donating sperm, isn't it? So, you can see why it's not necessarily taken up at the same level that sperm donation is, for sure. Hello, it's me, your host Rachel. So yes, this is sadly where our recording stopped. I'm very sorry that I couldn't retrieve those crucial final minutes of my conversation with Olivia. But to close out our conversation, after this point, Olivia and I briefly mentioned that unlike sperm and egg donation, there is no surrogacy equivalent at the fertility clinic. So if you need a uterus via a surrogate to grow your family, that is certainly someone you'd need to find and bring to your clinic journey yourself. And then I asked Olivia about how the fertility clinic thinks about the LGBTQ population and what sort of percentage of their patients we make up and how they think about inclusive care practices for us. I'm really mindful not to speak for Olivia here, but she did mention that the LGBTQ plus population makes up about 25% of FA's patients, and that solo parents are a growing portion of their books as well. And of course, those two groups aren't exclusive of one another. Olivia mentioned how important we are as a community to the clinic, and that thinking about providing healthcare for us is top of mind for FA, including in some of the training that they do with staff, and that they're going through the process of being certified with Rainbow Tick at the moment, and that they're consistently reviewing things like their website and other documents and policies. I was so grateful for Olivia's time and knowledge for this episode. Many people within the LGBTQ plus community had mentioned Olivia's name and how she was a real bright spot in their conception journey, and that they loved working with her to grow their whānau. Our community is very good at sharing resources and recommendations where we feel seen and authentic. So thanks to those who mentioned her, and thank you to Olivia for the work she's doing to help queer families grow and flourish all across Aotearoa. Thanks for listening to this episode of Proud Conception. If you enjoyed this episode, please consider passing it on to someone you think might connect with it as well. Don't forget to follow the show and leave us a review on Apple Podcasts and Spotify. And come hang out with us on socials. We're just getting started on Instagram. We're at Proud Conception Pod. Until next time, take care, and let's keep building a world where our little ones feel seen, safe, and proud.